So there was very interesting new data at ASH this year with CLL. Three particular abstracts that caught my eye: the UNITY U2 versus obinutuzumab-chlorambucil frontline clinical trial, the LOXO 305 phase 1/2 data, and the randomized data looking at the use of Ibrutinib or observation in MRD negative patients in the CAPTIVATE study. So just talking about the U2 study to begin with, this is a large international randomized clinical trial comparing Ublituximab plus Umbralisib with obinutuzumab-chlorambucil. So Ublituximab is a novel CD20 antibody, and Umbralisib is a PI3 kinase inhibitor, but it also has inhibition of a protein called casein kinase epsilon 1. And the point there being that the off-target toxicities and the immune-related toxicities should, in theory, be less with that combination. The study was roughly equal in terms of frontline and relapsed patients, perhaps slightly more in the frontline setting. And we saw overall in the whole study a progression-free survival benefit for the U2 arm, both in frontline patients and indeed relapsed patients. But I think if you look in the kind of study details and take those kind of different groups together, it may be challenging to see where the U2 regime kind of finds its niche. Certainly in the frontline setting, we've now got the option of Venetoclax obinutuzumab as fixed duration therapy following the CLL 14 study, and also acalabrutinib plus or minus obinutuzumab following Elevate treatment naive trial, both of which had obinutuzumab-chlorambucil as their control arm. And if you compare across studies, which of course always is challenging and has its caveats, it seems to be that BCL2 inhibition or BTK inhibition probably provides superior disease control in the frontline setting in older patients. So where U2 will fit in there, I think is challenging. Certainly, we like to see data in patients who've been previously exposed to novel agents, and there is a small cohort in the relapse setting that had prior novel agents, predominantly BTK inhibitors. Less than 15 patients, though, but the response rates are just over 50%. So whether the U2 regime will find its niche there, it's difficult to say with other novel agents coming along. So I suppose we await to see how that regime is used. And actually, there's been some interesting phase 2 data just published in Blood, looking at patients who are intolerant to prior kinase inhibitors. And it may have a role actually in that setting, perhaps. So that was the U2 study. Moving on to the kind of post-BTK space, there's some very interesting data with a novel reversible non-covalent BTK inhibitor called LOXO 305. So the study was presented in two abstracts: mantle cell lymphoma and non-Hodgkin lymphoma in one, and CLL patients in another. So Anthony Matto presented data on 170 relapsed refractory CLL patients. Median number of prior lines across the whole study was 3. Those who had a prior BTK inhibitor had a median of 4 prior lines. And these patients were a high-risk cohort. So a number of things to say here. First thing, very minimal toxicity. I think really kind of marked actually how little grade 3/4 adverse events occurred. Also, very little atrial fibrillation. Very few, I think 1% or 1.5% of patients had stopped due to toxicity. So very impressive safety profile. Early days from that point of view, and of course the follow-up's relatively short, but certainly it's very encouraging that the toxicity profile is very good, because we've heard and seen over recent years issues with tolerability of some of the BTK inhibitors, predominantly Ibrutinib, from some of the non-clinical trial real-world data that's been presented. But I think the really encouraging thing with this study and these data are the response rates in patients who are extremely heavily pretreated, patients who'd either been intolerant or resistant to a prior covalent BTK inhibitor, and indeed patients who'd received a number of novel agents, both BCL2 inhibition and BTK inhibitors. And the response rates look pretty equivalent across a number of these subgroups. Now, of course, when you start breaking the numbers down, they're relatively small numbers of patients in some of them. But even so, I think it's really encouraging early data and certainly providing kind of early proof of principle that this agent and this class of drug is particularly effective in this setting. What was also interesting is a number of patients had the CIS481 mutation. So this is obviously a group of patients who have been resistant to BTK inhibitors, covalent BTK inhibitors. And I think, that's really encouraging. We're seeing responses in that group as well, and certainly speaks to the mechanism of the drug. So overall, this study is really interesting. It's early on in terms of its development, but I'm sure we'll see more in this space as this phase 2 develops and follow-up lengthens over time. And then the third study that caught my eye was the CAPTIVATE study. So this is an interesting study, primarily because it's really introducing a new way of thinking about randomization in CLL. So it's taking patients who are both MRD positive and MRD negative at the end of Ibrutinib plus Venetoclax in the frontline setting. So giving a fixed duration therapy initially, and then randomizing patients on the basis of their MRD results. So providing effectively a response-adapted approach to the management of CLL. Now, historically, we've been used to seeing that kind of response adaptation in, Hodgkin disease with PET, for example, over recent years. But we haven't really seen much response adaptation in CLL. And so this is a really nice example of that. Patients who are MRD negative at the end of their fixed duration Venetoclax plus Ibrutinib were randomized to observation or ongoing Ibrutinib therapy. And the 1-year disease-free survival was presented. Now, some caveats there. It's short-term follow-up in terms of a 1-year disease-free survival readout. And also the numbers, unfortunately, are relatively small in those two arms. So actually kind of providing the necessary power to detect differences there may be challenging. That said, I think, there's clear evidence that this kind of strategy is the right thing to do kind of moving forward. And actually, patients who were observed following stopping therapy in the MRD negative group seem to do potentially just as well as the Ibrutinib group. But I think we need to follow that study up further to understand more about it. But I'm sure we'll see more of this kind of study moving forward in CLL. It's really important that we use MRD and the tools that we have to risk adapt in our study designs.